Good afternoon, everyone. I'm a relative latecomer to the field of innovation. I started life as a surgeon, as an academic researcher, and I only came into innovation in my mid-40s, even 50s, and I'm still learning. And the people I learn from are the financiers, the VCs, the marketing people. And one of those, this was actually at the J.P. Morgan meeting in San Francisco a couple of years ago, where Paul Jóhannesson, the then CEO of Oculis, and I met something like 100 VCs who all said no. And one of them met us with a wonderful question. When we sat down, he said, "What problem do you solve?" And this stuck in my mind. This is the best question I have ever been faced with as an innovator. What problem do you solve? And I will say to you that your problem is more important than your solution. And when you start out in innovation, you need to pick a problem that is worthwhile, preferably a big problem, an important problem. A problem that you can solve and it has consequence, because you also need to meet the so what question. So you have your technical solution. So what? So you're going to solve this problem. So what? Can you convince me, can you convince each other that the problem that you are going to solve is worthwhile solving, that there is some consequence, some benefit, some commercial benefit from solving that problem. So think in terms of problems. Be a problem-solving person rather than being a technology-based person looking for a problem that you may or may not find. So the ABCs of innovation, I see it, is quite simple. You need to define a problem that is worth your while. Basically an important problem, a problem that at least someone, and hopefully many, will have benefit in being solved. You then obviously need to find a technical solution that works. And you need to convene the team that can complete that task. This is all you need. Now, I'm going to share with you some of my experience. I have involved in, well, a number of 5 startup companies, and I'll tell you about 2 of them. Now, both of them have to do with diabetes. Why? Diabetes is the biggest epidemic in the history of mankind. We now have almost 500 million, with a B, people with diabetes around the world. It has tripled. It's 3 times what it was at the turn of the century, just some 20 years ago. And it's expanding rapidly, mostly because we're overeating and getting fat. So it's a huge problem, huge public health problem, not only in terms of lives, but also in terms of money. Here is one slide that suggests that 20% of the health expenditures of the United States goes into diabetes, and it is rapidly increasing. So a huge amount of money goes into treating diabetes, and the cost of blindness and losing limbs and kidney failure and all of the complications of diabetes and early death, of course, exceeds the monetary cost of the health issue. Now, what is we focused on? Because you can't focus on the entirety of diabetes, so we focused on diabetic eye disease. Now, I happen to be an eye doctor, so this was clearly in my field. And blindness is one of the main consequences, one of the major complications of diabetes. diabetes is the most common cause of working age people going blind in most countries. So it's a huge cause of blindness. It's a major complication of diabetes. And what we do currently to treat this is what you see here. We take a needle, we stick it into the eye of people, and we inject a drug that helps prevent blindness. And this can be done. It's not terribly pleasant. And it is not available to more than maybe 10 or 20% of diabetics, because most people with diabetes, they do not have access to the facilities, to the experts that can give them this type of care, so the other 85% simply go blind. Now, what is the solution? The solution, we think, is eye drops. Rather than sticking a needle in the eye and injecting the drug into the eye, is to develop eye drops that deliver the drugs into the eye in an appropriate way. The difficulty was that it has been known since the beginning of time that that cannot be done. All eye doctors know that eye drops are useless for the back of the eye. So when Thorsteinn Loftsson and I set out to solve this, and the technical solution, the cyclodextrin nanoparticle, is something that Thorsteinn Loftsson created. So it was a fellowship of the problem coming from me and the solution coming from Thorsteinn. Everybody said, "You're crazy, it can't be done." And even today, there are some people that still say that in spite of the available data. You know, the success takes time, and this is from some of our animal work showing basically the delivery of the drug into the eye, and you will notice the reference year, 2007. This was basically when we saw, yes, we can deliver drugs to the retina. We are going to make it. It's 12 years ago. Some of our good friends in Japan. So one of the things you need to be successful in innovation is to have good friends. So my friends, my old fellows at Duke, Ohira, Tanito, did some studies for us in Japan, and you can see this is diabetic macular edema, this sort of mountain of edema in the retina, and then after treatment, it comes back to normal. So the clinical data started coming in even as far back as 2011, 2015, but still at that time, most people didn't believe us because they knew it could not be done. So it's a long struggle, and you basically have to win the science before you win the innovation. And that's what we did. So this is an issue of scientific presentations and publications, of public money grants from RANIs, from the European Union to support the development at the time when nobody believes this can be done, getting the academic success, the gold medals, and the recognition for the good scientific work. And it was only at that time, after that time, that the financiers finally got convinced. First Brunner here in Iceland, and then Novartis Ventures and others that came in with a substantial amount of money to bring us sort of through the home stretch. And so now we are in a state where our plan is to bring a drug to market in 2 or 3 years that will treat or be an available treatment for the 25 to 30 million people around the world with diabetic macular edema, to basically prevent them from going blind and make our investors rich at the same time. So that is the Oculis story. I think it's a success story, even though we're not quite at the end point yet. But let me go on to another company that we also founded pretty much 10 years ago. This is called Risk or the brand name retina risk. And this is also in diabetes, also the big diabetes problem, but now this is an information technology company. So you can say we're dealing with the same overall problem, different part of that problem, but a very, very different technical solution. To bring you back a little bit, and you remember I told you diabetes is one of the most common causes of blindness in the world. And in the early 1980s, Iceland started screening for diabetics on a regular basis, eye screening for diabetics on a regular basis. And the consequence of that you see on the screen. The blindness rate of diabetics in Iceland went down almost 5-fold in the of the 1980s and the 1990s. A tremendous success and something that has been maintained since. This was copied by many, including, for example, the British. And the British declared just a couple of years ago in a publication that diabetes is no longer the most common cause of blindness in working age people in the UK. Just think of what a huge success that is. Now, while the annual screening works and it prevents people from going blind, and it is cost effective in that it reduces the enormous societal cost of blindness, it's still pretty expensive. And when we screen all diabetics every year, only 3 out of 100 are referred for treatment each year. The other 97, they simply get a slap on the back and come back in a year. So the effectiveness of it is rather low. So we asked the question, can we do this in a more cost-effective way? Basically what we're doing is we're using the scientific method to get health economics improved. Science for economics, that's a new one, isn't it? And what we propose to do is to go away from the annual screening where all diabetics, the high risk, the medium risk, the low risk ones, are just screened once a year. You know, one size fits all. That is the old way. And we said, let's do individualized screening. People talk about personalized medicine. So we said we will build an algorithm that can predict the risk. So we can identify high risk individuals, medium risk, and we will have the screening frequency appropriate to the risk. So that those who are high risk, well, they'll be screened very frequently. Those who are low risk, they don't need to come every year. They can come every 4 years or 5 years, depending on the actual risk level. So it's basically a personalized approach to allocate the healthcare resources according to the individual risk, not some average or some traditions, but to the individual risk. And we built an algorithm. This is together with Thor Aspelund, Arna Guðmundsdóttir, and you can see this on retinarisk.com on the internet, and also if you go for Retina Risk in the App Store, you can download our app, and please do, and give that to your diabetic friends or family members. Now, if you put in the appropriate risk factor levels, your blood glucose, your blood pressure, duration of diabetes, etc., you will get your personal risk assessment. So this particular person has a 2% risk, 2.1% risk of developing sight-threatening retinopathy in the next year. This has been validated extensively in the UK, in the Netherlands, Denmark, etc., in more than 20,000 diabetics. And you can see sort of the breakdown. This is from the data from the UK, from about 10,000 diabetics. And you will see that the majority of the population, more than 60%, is in a very low risk group. You know, 0 to 5% risk of developing sight-threatening retinopathy in 2 years. Whereas about 8% is at a huge risk. There is more than a third, more than 30%, that will develop sight-threatening retinopathy and risk going blind in 2 years. So it makes a lot of sense that you should allocate your healthcare resources to this group in particular, and basically not on this group here. Reduce the intensity of healthcare for this group and increase it for this group here, of course, again, on an individualized basis. And what we have seen with the experience in the UK, in Norway, in other places, is that if you do this, if you run your healthcare system in this particular field based on individualized risk assessment, and thereby increase the service for the high risk, but decrease it for the much bigger low risk group, you can save on healthcare costs by between 40 and 70%. Just an incredible number to think that in an established field of healthcare, you can cut the cost in half and make it better at the same time. But this is what science can do for you. And the important thing to keep in mind is that if we can do it for diabetic eye disease, we can also do it for diabetes. We can also do it for cardiovascular disease. We can also do it for most of the chronic diseases of the human body. And the chronic diseases are responsible for 2/3 of our healthcare costs. So just think, if we can save, I'm not going to say 40%, but let's just say double digits in percentages from 2/3 of the healthcare costs. You know, this would be 1 or 2% of the GNP of the United States. So these are serious monies. That's a big problem. What problem do you solve? Come back to that. It's a big problem, and we have solved it in this, narrow field. We've done the science. The science is robust, and it can be expanded to healthcare in general. I mean, to most of healthcare, perhaps not all of it, but the majority of it. So the opportunity to use the scientific approach to have meaningful improvement in the health economics field, in delivering health care in a personalized way, in a focused way, delivering it to those who need it and pull back on those who don't need as much. This is before us. We can do this together. Now, I basically pretty much told you this slide, so I'll just leave it for a second and then move on to our app. This app has been released. It's been on the market for a couple of months now. This is focused for the individual diabetic patient, for him or her to be empowered, to be educated and motivated about their disease so that they can punch in their risk factor, their blood glucose, their blood pressure, things like that, and basically get a reading, this is my risk, and then they can play with it and say, well, what if I improve my diet and my blood glucose goes down a bit, and then you can see the risk going down. So this is empowerment and motivation for the individual diabetic patient to help him or her manage her disease. So finally, for my last slide, to come back to the beginning, to the ABCs of innovation as I see it, it's the problem, baby. Make sure that your problem is that you're solving something that makes a difference to people, to commerce, that the problem is worth your while, that you're not wasting your time on something where somebody just goes, so what? find the right people, find the people who can help you with a technical solution. And of course, ultimately, that has to work. But if you have the problem right, you will find the people and you will create the technical solution. Thank you all.